Oui, il a déjà reçu le signal et ok, on peut commencer.
Très bien.
On peut commencer.
Good morning, dear colleagues, dear students, dear guests, and welcome back to this fifth edition already, on the YouTube channel of University of Luxembourg. For this fifth edition of this, as we called it last week, Bridge of Knowledge and Exchange of Experience between China and Luxembourg, we are addressing a crucial question that most European governments are debating at this time, which is the exit strategy out of confinement. And once again, we can only be most grateful to our colleagues from China, who have, of course, some kind of 3 months advance on our experience over here, and who take the time to teach us about what they observed, how they acted, and which advice they can give to us to handle this really unknown situation. So it is my great pleasure to welcome today one of the top experts in this area, who is Professor Weibing Wang, head of the Department of Epidemiology at Fudan University in Shanghai. Professor Wang has a large and impressive international experience as well, having made fellowships in North America at Georgetown University, at the University of California at Los Angeles. He has done several projects together with WHO. So we are really, how would I say, we are really thankful to him that he accepted to take some time in a very busy agenda. After the lecture of Professor Wang, we will have an interesting discussion which will be shared by Professor Yihan, who is also epidemiologist at Fudan University. And on the side of Luxembourg, we are very happy to welcome today Professor Laetitia Huyard, who is leading the Department of Epidemiology at Luxembourg Institute of Health, and who is also developing the teaching of public health issues at the bachelor program at University of Luxembourg. So, Professor Wang, once again, many thanks, and we are listening to your feedback from the Chinese experience.
Okay. Okay. Thank you. Thank you for the introduce, and it's my pleasure to be here online to introduce the experiments and the lessons we have. Since 3 months ago, we have this epidemics first identified in Wuhan, China, and now I think it's had been a global pandemic in a very short time. So I think all of us have a lot of things to learn, and what I want to share, most of them we did not actually have a very clear answer. So I'm sure that today it's more like to be discussion and not a conclusion. So when the first case was identified in China, I think there is a lot of things we actually did not understand for this disease. So I think that is may be the main reason why this disease can can transmit so quickly, even on this on current situation that we have a very good health system in China and also in other countries. So there's definitely there's a lot of experiments we have, and also I think more lessons we have from China and other regions. And recently I just wrote some policy brief with other countries mainly in Asia, with Korea, Japan, and Hong Kong, Malaysia. We try to summarize a policy brief to take some message to other countries how we deal with the COVID-19 in Asia countries. But surely there is a lot of difference especially in the culture. So I think we needed to understanding the situation on the local culture and the local situation of here system. So I try to focus today's topic in three topics. The first is we have some evidence about the contagiousness of COVID-19, and the second is China's experiments, especially for the strategies, how the current strategy is effective, what is the experiments, and the last is how to get released from confinement. Especially when in Shanghai we have reopened the school from April 27, and in our campus we also have welcomed the second round of students to come back, and so I think we have some experiments can tell. And so for this content, I think as the scientists actually scramble to learn as much as they can about COVID-19 and the new this virus, but we still grappling with a number of major unanswered questions we needed to look into. But COVID-19 usually cause at least several symptoms than the SARS virus and also most virus. But apparently we now know that this disease is more easily transmitted. The reproductive number, that means how many patients they can transmit from one case to the susceptible populations. According to the WHO estimate, you may know that the first estimated will be 2 to 2.5. And then, according to the researchers on the Diamond Princess cruiser, the R will change to 2.28, but it's quite similar. And a recent study was published in Emerging Infectious Disease that changed the R0 to 5.8. So it is quite high. Higher than what the initiator expected. It is higher than the SARS-CoV and also the MERS-CoV. So I think it's quite clear, and this disease actually have transmitted so quickly. Even in the United States, we now witness the quick spread of this disease in the whole countries. So we now can identify that there's three main transmission routes. We transmit, firstly, I think mainly transmitted by respiratory droplets, as we usually understand, and also the contact transmission. Sorry, there is a typo error. And also now we have some evidence that may have airborne transmissions, especially when the Diamond Princess cruiser, the incidents. There's some researchers they raised up the question that there's maybe some possibility there's airborne transmission in the boats. and as a contact transmission, actually, there's also some evidence that contact transmission sometimes happens when respiratory droplets or secretions are deposited in a surface, and another individuals pick up some virus. But the exact time that COVID-19 remains infective are not clear. There's some research say that there may be last for several days, and now I think I will mention later that there's some new evidence coming out shows this issues. So this study was completed by my colleagues. They collect the samples in the environment, especially in the surface of different locations from 2 hospitals in Wuhan. And it's quite clear that there's some locations even in the patient's rooms and also in the workrooms of physicians, there is virus existing. They can be detectable, and I think this studies investigated the nature of SARS-CoV-2 by measure viral RNA in different areas, but they find that actually very little, very small particle, even the very micro, submicro, even meters of particle, they can, bring this virus, but these levels were reduced sometimes to undetectable after if we do the implantation of some sanitization procedure. That means that I think some sanitization is quite useful to disseminate the virus in the hospital. And so there's a new studies coming that they find that the viral load is highest in the upper respiratory tract. So there's data from clinical and biological studies that collect repeated samplings from confirmed patients, not only the upper respiratory tract, but also other feces, urines, but actually the virus is highest in upper respiratory tract. So that's why I think for most of cases, we are more likely to detect from throat samplings. But this is within the first 3 days from onset of symptoms. And other study, they said 1 week will be the most likely to be detectable in the upper respiratory tract sampling. And there's also some data suggesting that people may be more contagious around the time of symptom onset when we compare later on this disease. And so there's quite primary studies. They collect the samplings from several cases, but this paper was published in New England Journal of Medicine. They find there's a viral load in upper respiratory specimen. There's more, actually more easily. It is what detected soon after symptom onset, with higher viral load detected in the nose than in the throat. But just this morning we talked with the CDC, and actually there's some case we detect. We collect very longitudinal samples across different times, but these patients cannot be detected in the throat several times. But finally we find the positive results from these lung samplings. So sometimes, I mean, the virus may transfer with the time in the location within human bodies, and apparently infectiousness was estimated to decline very quickly within a week, as you can see from the fingers. After 1 week, the viral load will decrease very quickly. But sometimes we know that the detection of RNA does not necessarily mean that infectious virus is present. We needed to do the culturing to confirm that. And this study was conducted by scientists in Germany. They reported that the people infected with COVID-19 seem to be more contagious in the first week of showing symptoms. And during this time, they found a very high level of virus shedding, where the virus leave a seal to either infect other cells in the bodies, but or others in other people's, especially in the throat and the lungs. The researchers also find that after 10 or 11 days of first showing symptoms, people continue to have virus in their sputum, but in very low enough level that they could be discharged from the medical care. And but they actually testing a different type of samples. They detect isolates from sampling from the throat and lung, but not from stone samples. But in China, we actually did successful for detect the samples from feces samples. So there's a quite unclear that, and interestingly that we now know that in children, the pediatric patients, they usually have a mild symptoms and easily to recover from this disease. But a study we just submitted to the Nature Medicine, and we find that the patients, the pediatric patients who have symptoms of like vomiting, symptoms, who have not easy, difficult to recover from this disease. And also, when we back in these studies, they found the blood and urine samples never detect the virus from these patients. And they also found that the seroconversion occurred after 7 days in half of the patients, and in all patients after 14 days, 2 weeks. So that means there's there may be some antibiotics to be to deal with this virus in the human bodies. We now have very clear about incubation period. The largest one is 14 days, but this on average it's 5 to 6 days. But during this period, also there's a period that we named as pre-symptomatic period. That means before the symptom come out. So some infected persons still be contagious. So transmission from pre-symptomatic cases can happen before the symptom onset. That we have observed a lot of cases in China, and there's some cases have been documented in especially in the Wuhan city. Sometimes there's a cluster we do the investigations and then we find some pre-symptomatic cases or asymptomatic cases. But for the But there's a few reports of confirmed cases who are truly asymptomatic cases in China. We have documents quite a few cases who don't have any symptoms, but they are tested by PCR positive. So we, at this point, we cannot exclude the possibility of transmission. It may happen. We actually have contact trends in some clusters. There's a three sources of asymptomatic cases. The first is the close contacts of confirmed cases. The second is in the cluster investigations, we testing the people who have any contacts with the source case, and the third is for the imported peoples from overseas. They are required to have a 100% testing. Then there's several cases who are being detected by PCR, but they don't show any symptoms. So viral load that was detected in the asymptomatic patients was quite similar to that in the symptomatic patients. There is that suggests the transmission potential of these patients. So there is some. I think there is a controversy that the recent paper published in JAMA recently. They have points that they may help. They said these results may help expand reports from China, suggesting that the virus can persist in the bodies for at least 2 weeks after the symptoms clean up. But other people, they just say this sort of persistence isn't, sometimes the patients are more likely to not very contagious in the post-symptoms period. I think there's some argue about immune system, response to like children. Why the children they did not act very, very aggressive immune response to this disease, to this virus, but so therefore they have a very mild symptoms. But the problem is we did not find that. It's still for them, it's very easily for them to recover from the disease. I think that this virus I think the main strategies in China, we conducting the non-pharmaceutical intervention measures, including the first of all the social distance measures, and the second is the case and the contact management. Also, we propose the personal protection, environmental measures, and the travel-related measures. I think what is China to do is we try to interrupt the transmission links between the human beings. So what is China doing is we conduct or follow a very strategy in China, and it may not be replicated in other countries, but the China's government have a very centralized, powerful to intervene, to do the interventions for this, and so China actually have a rolling out the most ambitious and aggressive disease contaminant efforts in history, but so when the first case coming out within the 7 weeks approach taken in China, actually have averted and at least delayed hundreds of thousands of COVID-19 cases in the countries. We prevent local transmission and export of cases. And Wuhan, the whole city had been locked down, and taking and treat every confirmed patients, test every suspected case, and isolate every close contact. And recently, because there's a new cluster coming out in these cities, the government, they just initiated a very aggressive plan to test 10 million people, actually the whole population, a plan to test in this in PCR to identify who are infected by disease currently. So at that time, I think they actually organized the 19 provinces to support the cities in Wuhan. We dispatched a lot of medical doctors to these cities. We sent a lot of beds, critical beds in these cities. So this show you the case tracing and management of China. So basically, all the suspected cases are subjected to lab tests, and if they are confirmed, then they will subject to the isolation and the treatment. And if there's a close contact with a confirmed case or in the cluster or other situation, and there may some asymptomatic infections can be identified. All this infection case, the close contact people needed to be traced, and they needed to be under medical observation at least 14 days. And so for the case management, we separate subtypes about patients. Like there's confirmed case but for the severe case, they have to be in the critical beds in hospital. But for some mild cases, they can be in the camping hospital and temporary hospital for treatment. And for the susceptible cases, they have to in the organized observation sites, hotspots. They needed to be organized and observation for 14 days sometimes. And for the close contact, they also needed to be observed. And the policy will change with the time. And so for the peoples from high risk areas or regions, they sometimes they cannot enter in the major cities, or they needed to under observation for 14 days in organized spots. So there is a very strict policies we followed. And the government tried to set up the so-called 4 lines of defense. First line for the Wuhan, because the Wuhan city had been locked down, and the second line to prevent a major outbreak in Beijing. Beijing is a political center of this country, so all the people come to Beijing needed to be tested with PCR. And the third line is to stop the spread of disease in the Hubei whole province surrounding regions. And also there's the fourth line to stop the spread of the epidemic nationwide. So there's they increase the response level in the whole countries to stop this disease. There is a community management and also the social distance and the close of the market and the school. And we will discuss this later. And we actually have set up quite, I think, effective case reporting system that actually basically this disease, kind of like SARS and COVID-19, they are required to report the new case within 2 hours after diagnosis. And all the information needed to be checked by CDC with 2 hours. And with if the new case coming out, they have to collect the samples from the patients and also the close contacts within 24 hours, and we have to have a test results within 8 hours to show the results. But there's a doubt about the system because of some kind of delay in the first wave of this outbreak. But personally, I think we actually have a quite good reporting system, but maybe a little problem of political issues. Some government leaders, they sometimes compromising with other issues. So I think basically this system is quite weird. And I think from this experiments we have, I think the core is the testing. So as a lot of countries or WHO, emphasize the testing for COVID-19 is a way to lift confinement, to restrict. So I think the test capacity is very key to how to exit this restrictful confinement. It's very crucial, of course. It's very crucial for, of course, to help the treatment slaves and hospitalized people who are infected. And testing also is very important in the bigger public health picture. Mitigation efforts, helping investigators to understanding the prevalence, spread, and the contagiousness of the disease. And currently, we all know that there's 2 kinds of testing available for COVID-19. Viral testing, that means PCR testing, and also antibody testing. But when the outbreak was initiated in China, we don't have antibiotic testing. We only have viral. I think when after the first sequence of RNA was published, and then we have testing methods available to do the testing. That changed a lot. So it's in the first stage. Actually, we don't have a capacity to test all the peoples in Wuhan. So that caused a lot of problems because we observed and also the ICU beds were not enough to hospitalize all the patients who needed to be taken care. So there's quite a proportion of cases they're living in the cities and to cause a lot of transmission outside of the city, and also some people may go outside of these countries. So 2 kind of testing. The viral testing tell us if you have a current infection, and antibody testing basically tell you that if you have a previous infection. But in this in this picture shows you that actually it's, like the U.S. actually have moved very slowly when compared with South Korea. South Korea is a very good example to increase their capacity of testing very quickly, and then they control this disease very, very well. As I said, there's two testing available. Now I think we have quite multiple choice to have. But you know, as I know that the PCR testing is quite problem in China, because we have experienced a lot of cases who have sometimes positive, negative, positive. So when we do this testing across different time, they have changed a lot. Especially when in the morning meeting we discussed with CDC, there's some patients who have a very weak positive by PCR, like in the school children. There's a school children who did not have any contacts with confirmed cases, but he is a very weak positive. But it caused a lot of pandemic society because these students have go back to the school, and but we guess that it may be because of the quality of testing kits, not actually the positive case. But there's caused a lot of problems, and also the serological testing. And China, have initiated a very big project to cover 10 provinces to test a lot of people's. But the problems we faced with now is the agreement of the different type of testing kits is quite problematic. We cannot find a very, very good, testing kits to do these studies to really understanding the situation of antibiotics in the people. And sorry, I need to be quick. So the testing, so there's a very good examples for the testing can be used to manage the COVID-19 disease. There's efforts. The name is testing, tracking, and tracing. That means TTT. To be used to deal with this pandemic, and as I said, serological testing among targeted populations can be used to understanding the immunity of the populations. So the priority for the molecular testing or initiated remain for ensuring safe and appropriate medical care. And so I think the priority for testing, the population is hospitalized patients. When some people, they are high risk for the disease, and also the health care workers. We know Shanghai, we just initiated the serological studies for the health workers coming back from Wuhan. I think there may be some findings that can remind us how important or what is infection rate in the health workers. And when the capacity increased, then testing can expand into suspect several cases and people who are in contact with the confirmed cases. So I think there's a lot of options, but there's according to the WHO, there is protocols to depends on the capacity of the testing. And so in Shanghai, we do a very strict for interpretation or interventions for we so-called inter-departmental cooperation combined with a precision approach. We have to very restricted information registration for all the people's enter in cities, and medical observation for all the travelers from the key epidemic regions, and check body temperature for all the people enter Shanghai, and medical observation for all from key epidemic regions, and mandatory health declaration by their employers. So that is, I think Shanghai have provided very good examples for the interventions and management of cities, and I think we have besides of imported cases, we have quite a long time did not observe any new cases coming. Fortunately, that we observed that the Luxembourg have a very good capacity of diagnostic testing, and I think average in OECD countries we have 27 per 1,000 populations, but Luxembourg is quite good, and we all know that US actually faced with a big problem in the first stage. So US, as you can see here, is quite low in the capacity of diagnostic testing. So that is the reason I think they actually have a problem to control this spread of disease. So South Korea have done quite good jobs in the control of disease. You know, with in the first case coming out, there's chaos, quite different situation. But now Korea have conducted almost 10 PCR testing per 1,000 residents, only behind Germany and Italy, and they do the very good tracking system. The positive people are checked and provided with treatment free of charge. The government to pay all the cost, and also Korea have developed a very diverse digital coding system. They use I think they use not only the CCTV, and also use credit card to GPS these patients and close contacts. So they have done a quite well works on the tracing and this TTT strategy. So a good example. It's quite similar to Singapore, because Singapore also very follow this TTT strategy. Yeah, so this is the Singapore's universal TTT strategy. They even more have initiated a very large testing strategy, reaching 2,200 testing a day for population. They established a network of more than 800 public clinicals who were active for the testing, and all the identified contacts. They have symptoms will refer to the hospital isolation. So that is, I think, is why Singapore have controlled this disease quite well. And So for the COVID-19 prevention, I think in China, we try to separate the prevention, the individual level and the population level. Individual level, we like do the health education to provide, to propose or to educate people how to do the respiratory and hand hygiene, and we especially for the health workers, we provide the protective equipment personally, and we teach them to how to do some the disinfecting the surface and objects. And in the population level, I think there's a quite different strategy. Social distance is one of them. And now WHO proposed that we needed to change this word to the physical distance, not just the social distance. And also avoiding group gathering, like markets and the shopping mall have been shut down after the break, and now we discuss the open of this, and the school closure and workplace distance and staying, the working from home. So all this strategy have make very positive results. I will show you this. Let me skip this. So from the experiments in China that we this article was published in Emerging Infectious Disease said when 20 of the transmission is driven by unidentified infection persons and high level of social distance will be needed. That means that if this society have a high proportion of the people, they cannot be detected. That require a lot of efforts of social distance. Even if more of transmission cannot be identified, the more efforts we need to contain this virus. So this is very clear to and this study is also published. It's published by my colleagues that they actually investigate the contact rate in different population with different age and in different cities. As you can see here, that the contact rate decreased a lot because of this social distance, and they directly cause a very low prevalence of the COVID-19. And interestingly, that we now find we do ecological studies to find that the children and also the adults coming to the hospitals, I mean the hospital visits decrease a lot, but not because of COVID-19, because of influenza and other infectious disease, and the data from US also suggested that they have a lot of deaths, over 80,000 deaths in US because of COVID-19, but the total number of deaths actually decreased in this period. That means because of social distance, because of this protective measures, and other deaths from other causes may decrease. So social distance works not for COVID-19, but for other, like suicide, like car incidents, and as other infectious diseases. So that would be interesting to see that. And for this reproductive numbers, we all know that when this reproductive number is below 1, that means the outbreak will decrease. will be controlled in some way. So in Wuhan city, in China, we actually have, in January 23, this line is a day that we shut down this city. So from this time, the reproductive number decreased very sharply, and then in the beginning of February, we have a reproductive number below 1, and then we, stably we control this epidemic. From the experiments from other countries, also we can see when the reproductive number was below 1, then we will have observed the decrease of the disease. The other countries also show this. I'll skip this, sorry. In these studies, based on this data, they build up a transmission modeling to study the impact of social distance and other strategies like school closure. They find that the social distance alone, as implemented in China during the outbreak, is sufficient to control the COVID-19. That means the social distance, if we can complement the interventions of social distance very efficiently, that is enough to control the disease. Where the school closure cannot interrupt the transmission on their own, but sometimes they can reduce the peak incidence by 40 to 60% or sometimes they delay the epidemics from these modeling studies. And this, I think this study also showed that the duration of social distance lasts in the first map is 4 weeks, 8 weeks, 12 weeks, and indefinitely, the whole time. Then sometimes they can change the epidemics. Even we use the strategy of social distance like 12 weeks or 20 weeks. Sorry, 20 weeks. We still cannot observe a very quick. There's still the second wave. Even only in these situations we can, control this pandemics. And this study also showed that it's quite difficult for us to, totally control these epidemics. Like in this, if we, adjust the interventions periodically, then there is possibility that we can delay the last waves coming, but we cannot totally control this pandemic. So the outbreak, we did not. It's less likely we can stop this disease, totally. Like SARS, I think we were expected the second or third waves afterwards. So there's some issue that there's some comments from recent research. They say that if we can get 30 to 40 of population immunity, is it, usually previously we said 60%. Then the research said really start to change the whole picture, and then they change the epidemics of these studies. But there's some other research argue that this may not be the case to happen like that. That means 30% to 40%, even the 60% may not be enough. We need to depend on the vaccine, because the whole immunity idea, we know that the England, they tried to adapt, but finally they, give up. So it is, there's this studies. The title of this study is "Ending the Coronavirus Lockdown Will Be a Dangerous Process of Try and Errors." So there's a quite risk. We don't have answer about how happens when we exit the interventions. So now we faced with a problem is we try to reopen the school in China. Actually, we have gradually reopened the school. We have now we have a primary high school, and even the primary school. The students, part of students, they coming back from into the school, so they needed to, like this in the school in Taiwan. They in Shanghai we also do the similar. We have like a cabin to separate the childrens to when they eating, and but we actually before that we have done a quite pilot study to understanding the antibiotic prevalence. They have a very low antibiotic prevalence, and they have a very low RT-PCR prevalence in these school children. So it seems likely that when 1 month after we have a first wave of students coming back, there's no incident patients coming out. So it seems very safe to reopen the school. But of course, we are very nervous about the government are very nervous about this. So for the exit strategy, especially because of the economy, the government worry about a lot of economy, the dropping of economy. So there's a big plan to increase the economy by constructions and by exciting the demand of so actually according to the WHO, if any government they want to start lifting the restriction, they have to for submit 6 conditions. The disease transmission is under control. A system unable to detect testing all the cases, and hotspot risk are minimized in vulnerable places. And school, workplace, and other places establish preventive measure, and risk of importing new case can be managed. Community are fully educated. But seems that in Shanghai we have met all these conditions. So I think that is why we have tried to reopen or exit the process. We have now degrade the response level into 3. That means we can have lifting some restriction, like we open the marketing, and we reopen the school. So I think that is the last slide. Thank you. I just gave you a very brief introduction about the strategy we have, but I think we may take some time to discuss if you have any questions. Thank you.
Thank you very much, Professor Wang. This was an impressive and very comprehensive overview, and I think we will have a very nice discussion now, looking at Professor Yihan, who is Vice Chair of the Department of Epidemiology at Fudan University, and Professor Laetitia Huyat, who is Director of Department of Population Health at the Luxembourg Institute of Health, and affiliated professor at the University of Luxembourg. So I leave the stage and leave the floor to both of them to start the discussion. Thank you very much.
Thank you.
Thanks a lot. Maybe if I may, I'm just going to give you a very brief
few key points on the way the epidemic is managed in Luxembourg. So you have our views from our side on what has been put in place, and from your presentation, that was absolutely fantastic, and completely rising questions that we are going through every day in the management of the epidemic here. I've realized you are facing somehow the same questions as what we're facing, and we have many extra questions for you, and to see how we can move forward for that. But thanks very much for this very comprehensive presentation. I've just one slide to give you a brief overview, and that's not a fully adapted slide. I just took it out this morning very quickly, just to give you an idea of how we are organized. In Luxembourg, we have the results from the labs are directly centralized at the Ministry of Health, and I happen at the moment for the crisis to work there as well. So we receive lab results on a kind of instant format. I would say within an hour we have the information on COVID positive cases. So we have the ability to contact directly the patients from the time we obtain the results, and we are able to isolate them at this stage. We don't hospitalize systematically the patient, but we isolate them at home, mostly unless they have specific issues. And we are following them as well on a daily basis through telemonitoring system, digitalized or by phone at different time points to see the evolution of the symptoms, and to be able to adapt as well to their practical questions about isolation, how they should manage about that. From that first day contact with the patient, we identify the contact and provide contact tracing system with quarantine for all contacts of the cases. We offer systematic testing for the contacts, and that has disappeared on the slide of this. We offer systematic testing for the contacts as well, and we obviously provide. Identify the different cluster and provide some cluster investigation and testing of clusters when they occur. Aside from that, we are linking the surveillance system with the research part, and we are, based on a voluntary basis, we are able to include every single COVID patients in studies, observational studies, where we have a much longer follow-up and much more detailed clinical information and different digital device that we're testing, as well as an extensive biological sampling, so that we can understand as well the background of the severity of the disease and the kind of immunitory phenotype that do bring to severe disease or not. And we're studying as well all the household members as part of the research. So that's basically how we are organized. It's very brief. And maybe I'll leave the floor to my colleagues, and then I may have a huge amount of questions and points to discuss. Okay, Professor Wang.
Sorry, I may drop off in the very important issues when you discussed. So can you repeat the last sentence?
Just the last sentence was maybe Professor Yihan, sorry for my Chinese, who's approximate. If you had something to start with, and then I can come back for questions.
I think he's coming.
Yes. Okay, so sorry for being late.
Okay, so if I want, I can start with questions. A huge issue we're facing in Luxembourg is our size. We are a very small country, as you may know, with 600,000 inhabitants, and we have the particularity of having 300,000 cross-border workers. So we are not an island, that's for sure. We are really interconnected with the different countries at the heart of Europe, which is wonderful in normal times. But that's probably our biggest challenge at the moment, because restriction of travel cannot really be implemented or cannot last. I mean, we would kill our own system by implementing travel restriction. This would be a very specific issue on our side. Would you have any epidemiological thoughts about how to find some kind of original approaches to this very specific aspect of our country?
I think Shanghai is quite Hong Kong. Also, my colleague in Hong Kong, we also discussed a lot about. I think for the Luxembourg is the high risk is from importation, of course. So how to manage this the risk from importation? It's quite essential to control the epidemics. So from experiments in Shanghai, I think we actually have two kind of defense lines. The first is we actually testing 100% of people's coming outside, and other than 100% testing, we do the observation for the older people's coming from outside for 14 days. We do identify quite a lot of cases from these populations, and so when we do this very restrictive follow, I think we actually prepared 2,000 hotel rooms for observation of this in these cities. And also the second I think we have done is to reduce flights. We cannot cancel all the flights, of course, but we can reduce the flights coming in, and then I think we have enough capacity to do the observation and do the testing, to holding and to find the new cases if they have. And the second I think defense line is we actually build up some specialized hospitals. We increase the capacity of critical beds if any if the outbreak happens, so we can have enough capacity to hospitalize these patients if they have. We have a lot of hospital actually in Shanghai. We have biggest hospitals is over 3,000 beds within one hospital, but we needed to have a ICU beds to treat these several cases if we have. So I think at this situation we have done quite well to control. But we because China is a very big country, so we did observe the bad situation in those areas because they don't have a very good capacity to testing and to management for the import. We have a quite long borderline, so especially for there's a civil case, they come back from Russia, and when they come into this country, come back in this country, they don't have any symptoms, but they are not isolated for 14 days. Then there's an outbreak happens. There's a case that they're coming back from European countries, students, but he actually was isolated for over 14 days. But after that, he, was tested with positive. Then she and spread the virus to several cases, and then that case came into the hospital for the diagnosis, and then there's over 80 patients have been confirmed because of these people. So there's a very high risk sometimes because of importation, but the problem is we need to do this screening problem very strictly when we have a high risk from importation.
Yeah. That will certainly be our biggest challenges, because here people are crossing the border every day. They come and work and go back. So just the quarantine system is not applicable, and that's where we're going to have to really think and probably come up with some experimental kind of solution and adapt and make mistake and adapt. I would like your epidemiologist's point of view on would there be any indicators that would have to be taken carefully or probably adapted to a country of our size, because obviously most of the countries, most of the indicators that are developed at the country level are usually covering a much larger population, and we do have lots of fluctuation, obviously, in our indicators when we're monitoring them. What would you recommend us in terms of really close monitoring or close follow-up of indicators? What would be your point of view?
The close of sorry, a big
type of indicators. For example, if we do have some fluctuation in our indicators because of the size of the population, so we do have random variation that is bigger than in other countries. Is there specific recommendation you would have for us on that?
You mean the indicators that we can use to
epidemiological indicators to monitor,
to monitor and to change the policy, right?
Yeah. Or would it be as any other country?
Yes. I think yes. You know, it's a very essential or important indicator is if there is any cases from community transmissions. If there's community transmission, that means there's a high risk of outbreak happens. So we actually always worrying about the community. So as I talk in the slides, that China initiate a new big project to test 10 million populations in Wuhan city. We plan to screen the whole population in the cities, because there's the 6 new patients coming out. They have a community transmissions. So when a community transmission happens, we have no idea how many patients, how many infections happens in the community, but we cannot detect. So so this is, I think, very important issues we need to focus on, and also I think. As a lot of countries have done the studies, a serological study, like Iceland, they actually done antibiotic studies in the whole populations. Even I think this is every country needed to do to evaluate the prevalence of antibiotics to see that what we can do for the next step. So China is also conducting the studies, I think, in the future 2 months to understand the situation that we have. I think this is a very important indicators to.
That's something that has been done in Luxembourg very recently. Last week, we got the first results on the with systematic PCR and systematic serological approach on a sample of 1,800 people. Still, we're not Iceland, unluckily, and because the cross-border is still occurring all the time, then these numbers should be probably taken more carefully than in other settings. So that's something we really have to take care of.
What is the prevalence of antibiotics in the population?
Just to sorry, I'll go back to that right now. Just to give you the accurate numbers. So we had 1.97 people who had IgG response, and we had 0.3 1% of people with active infection with a PCR positive. And that's what we found in systematic screening in nursing house, or we're ranging for positive PCR ranging from 0.3 to 0.5. We don't screen systematically with serological test in nursing home, but basically we were around 2%, which is...
So that means that actually have remote infections in this population, because quite high, not so high, but several cases in IgG positive. And I think it's remind us that because we have actually established a surveillance system for the fever clinic, so I think that's very also important indicators for detect the signals if we catch up some the positive cases from influenza like patients fever within the fever clinics, then that I think that implies us a lot to change the policy to increase the response level.
I do have a very, very practical questions. We are facing situation where we have people who are testing positive for a long time, and as you said, that are testing positive and then negative and then positive, and this kind of situation where you never know. Sometimes with symptoms reoccurring, then it's a bit clearer, but sometimes with no symptoms. You keep the isolation until the end of the signal, and how do you consider this kind of late positive PCR testing?
Yeah, the CDC guys told me that actually there's over 95% of these patients actually are not COVID-19 patients. Mm-hmm. They just it's because I think most likely because of the quality of testing kits, but for precautions, they most likely they are not let the patients go. They will keep these patients for at least one negative results, and then they will dismiss for this patient. Professor Lu have been here.
Yeah,
so
sorry. Yeah.
Yes, Professor Lu, if you have any suggestions for the question from Laetitia, yes, welcome, and please.
Yes. Okay, so I just want to add some comments. So am I clear?
Yes, very, very good.
Okay, thank you. Yes, I just want to add some comments for any potential, transborder or cross-border transmission from any other countries to Luxembourg, because in Shanghai we have very similar questions from, for example, from European countries and the United States, and also from our neighboring provinces. Yeah, actually Shanghai is a very small area, but we have a very larger population size. So, for example, as Professor Wang just mentioned, in the late March, maybe 2 months ago, we have increasing cases or increasing students starting abroad, like in the United States and European countries. And now we just call it, we have established a strategy against this kind of any potential transmission. We have established a closed circle. So that means when our Chinese students arrived in airports in Shanghai, we just, so we just assured this kind of students, they cannot contact or they cannot have any contact with other Chinese person except our working staff in the airports. And when they arrive in the airports, they will be classified into different groups, like high risk, middle risk, or low risk. It depends on where they come from. Actually, maybe several months ago, the foreign countries, all of the foreign countries are at low risk. But unfortunately, as you know, now European countries and United States and our neighbors like Japan and South Korea, they become middle or even high risk. So, and then they will get some further classification. For example, some of the students, they just a native person in Shanghai. Okay, they will be take to hotels. Professor Wang just mentioned we have reserved a lot of hotels for medical observations. And if they just live in some neighboring areas like Zhejiang province, Jiangsu province, or any other provinces, and we have already arranged some working staff from every single province, and they will arrange further transportation directly from our international airports to their native places. So that means they will not stay in Shanghai for further medical observations, because other provinces, their government, their staff will arrange for their medical observations in their native places. So I think, I'm not very sure, because as you just mentioned, the Luxembourg actually is also a very small area. But if possible, maybe you could arrange some specific hotels or medical observation sites for persons from different countries. For example, I'm not very sure. So currently, for you or your country, China will be classified as high risk or low risk. And if some people traveling from China to Luxembourg for some business or any other things, they will be placed in a specific area. And if somebody from the United States, I think, okay, so we will arrange them in a specific site, because in now currently and in near future, the United States will be absolutely classified as a high-risk area. So that means person with high risk of transmission of COVID-19. So, I mean, different persons from different areas with different risks, they should be placed in separately, and to ensure no further cross-transmission between these persons in medical observations. So that's my...
That's a very good suggestion. We probably have to discuss at the European level, because people flying directly to Luxembourg or to other countries nearby and then cross by cars, and that's something that really is probably the next challenge for Europe, is to have a common approach to extra-Europe travelers. Intra-Europe, this probably is not controllable at all, but extra-Europe definitely... that will have to be the question. I would have a very generic question. What do you think, from your epidemiologic perspective, what were the key debate or challenges where you had to really convince the authority, or where you had to really struggle for some specific ideas? What were the key debate or challenges in the whole epidemic process, or in the whole exit strategy?
Okay.
So for the question, if there's no, I think there's a problem of internet. So the question, I invite Professor Wang, if you want to answer first.
I think the challenge, the big challenge we have is, I think actually we actually conducting study to monitoring and to anticipate that the second wave of the case. So so we have no idea actually what is the proportion of asymptomatic cases in the community. So why this new cluster happened again in Wuhan cities? Because we have actually have a quite long duration of zero new case in these areas. But several days after several days, there's a new outbreak happens. So that is, I think, we actually consider this situation a lot, because that makes us to consider that there's a very high risk of the second wave and maybe even the third waves. So the shutdown of city cannot last forever. So we have to, reopen all the facility and shopping malls and the schools. But think that the risk in the community transmission still there. So it seems there's a lot of controversy or consideration how to manage it and how to even for the government, it's very difficult for them to decide because the risk is there, but the economic pressure is also there.
Right.
There's conflicts. Yeah.
Yes. Since I'm coming from Wuhan city, I was born there, so I also heard of this bad news. But fortunately, the local government take immediate actions. So the suspect patients or person, they are immediately accept to do the screening of the virus and do the therapy and accept the therapy. So I think we are not waste time if we have this kind of issue happen. Unfortunately, yes. And Professor Lu, can you share with us some comments?
Yes. I totally agree with Professor Wang, because actually now we have a balance. We must have a balance between the economy or economic development and the further or continued containment measures against the COVID-19, because all of us, we believe that the pandemic could not be terminated in the near future. Yeah, maybe the whole year or maybe the several years, or we don't know. We totally have no idea. But actually, as Professor Wang just mentioned, and not only in Wuhan, the city of Wuhan, but also in several other, maybe in 2 other cities in northeastern China, we have identified 2 chains of transmission, and in which maybe each chain has, maybe more than 80 or more cases were identified in both of these 2 chains. So the problem is now, actually, I have to say that, unfortunately, we don't have enough knowledge or accurate knowledge or understanding of how COVID-19 transmitted in communities. We don't have the exact number of asymptomatic infection in populations. In Chinese population or in European populations, the same thing. So that has a further challenge how to control them, or how to contain, mitigate the pandemic, epidemic, whatever. But on the other side, we have to develop our economy, because we have mentioned it many times. China is a very large country, and we have a larger size of population size. So if we lose our economy, we cannot have enough funding, personnel, or anything to support our further fight against the COVID-19. So it's just kind of balance. And okay, so regarding the topic of this of today's discussion, we should say something about how to make the balance, but actually we don't know how to make the balance. We just try it. We just explore any potential balance. So if we open more shopping malls, more schools, or more public venues, and we don't have any case, oh, it's okay, 0 case. But if we have one new incident case, so shall we close maybe 1% of the shopping malls or schools or any other places, or maybe 20%? We don't know. So we just try. Yeah. So sorry, that's my comment.
Yes, Laetitia.
Yes, I think that what you're saying is really interesting, and the thing is that what you're describing is really a target to 0 case, and that's probably what we'll not go to in Europe, because we have started reopening before we have reached 0 transmission. So we know we have running transmission, and the question is up to which threshold do we keep that up to? And this issue about a threshold and when do we act, and do we accept 1 case? Do we accept 2 cases? Do we think our contact tracing is sufficient enough to accept 2, 3, 4, 5, 10, 20? Is probably one of the biggest challenging questions we have at the time, because we have very interesting means to be able to investigate a full population or to do comprehensive testing if we want. Well, in Luxembourg, it's a challenge because all the population will have changed the following day. But we do have lots of possibilities of testing, or we have this wonderful serological test that we don't know what to do with it at the moment for the quality issues you were raising. You're planning on using them, but I'm not too sure you are using currently this test to monitor your population. So we have it in the labs as well, but this kind of threshold and what kind of risk is acceptable, which is probably as well a cultural issue, is probably one of the biggest challenge for the next decades in epidemiology. What the level of risk is acceptable.
Yes, but fortunately that every different country actually complete different strategy and interventions. It's just like very large experiment studies. So let's see, what happens.
Worldwide experimental study. That is true. Yeah. But that's something. It's even very difficult to just define clearly the experiment, because just knowing in Europe what are the other countries precisely planning to do and to act, even at the European level, even being in the European Commission meetings, you sometimes learn it by the press, and that's very surprising. But we are doing a worldwide experimental study. It would be so wonderful to document it precisely so that we can adapt from each other. That would be probably the major improvement in transparency of public health actions around the world. That would be a wonderful outcome of all this crisis.
Yeah.
Yes, Laetitia, if you allow, I would like to share with all of you 3 a paper from the Journal of Science published in April from the Harvard Medical School. So they published a very interesting paper. The title is Projecting the Transmission Dynamics of the SARS-CoV-2 through the post-pandemic period. So just in conclusion, in this paper, they mentioned that the virus will definitely stay with us at least until 2025. This made me crazy, because if we have to keep the social distance and also wearing the mask until still 5 years, it will be very tough for human beings. And also they mentioned very interesting point I would like to listen from your expert views, is they mentioned that even if we get the vaccination, if we get the vaccine, we are not 100% sure that the vaccine will work. Maybe the final result is not as expected. So this is another question. And if the vaccine doesn't work, then they mentioned that in the future we have to live with this virus like the flu is a super flu. And they mentioned that we need to keep our healthcare system not saturated. We need to control that the ICU, intensive care, can be used, and they mention as well, the last point, but not least, is they think that the COVID-19 will be the first killer for the aged people, for the old people. They think that maybe in the near future, 5-10 years, a lot of people will die, not for cancer, but for COVID-19, or for both. Yeah. This is just one point I want to share with you, and if you want to comment on this. Finally, close our webinar today. Yes.
You wanted to finish on an optimistic point, is that right?
Maybe first the bad point and then good point. Yeah.
I mean, yeah, it's probably there's certainly there's very nice models circulating, but there's still very little data to really support one or the other model, and we're still all blinded and trying to try to guess, or at least to get ready for different scenarios. I think this the amount of learning that we have gone through over the last few months, and that we'll still go through in the next few months, is probably amazing. And I'm not going to comment on the specific papers. It's one of the possibilities and scenario that is unfortunately possible. We've seen that the target to zero transmission from the Chinese experience, that is, I mean, in China, there has been an incredible work being done. I mean, an incredible management of the epidemic. I mean, having a look at the beginning, it was like, yeah, oh, that's China. That will never be possible in Europe. I mean, never, ever. We'll lock our people in a house to manage an epidemic. This is completely unrealistic. But yeah, we've done it, and probably thanks to China, who has started. Otherwise, probably European authorities would have never had the courage to go into that direction. So that was one step. We're now facing the limit because of still some cases arising, as what we've just been discussing, or because we are probably going to survive to COVID, but we may die from our economy afterwards. So we're probably going to have to think about what do we accept in terms of risk, and how do we adapt ourselves, which means accepting that there's a running epidemic at a low level, accepting that we may end up in resuscitation care at some stage, and making sure we have space to go there. So yeah, this is the very important things. But I would like just as a last final word from my side, and I will let you finish on your side. I would really like to really underline how China has managed the epidemic. I know there's lots of controversy, but I mean, it has been so courageous from your country to really implement these completely crazy measures at the beginning. I mean, some people say it should have been more. How can you do more? I mean, I'm not too sure how you can do more than what has been done. That's a very confusing point on my side. I mean, you're already still doing much more than what we are doing, because we're not limiting travels as much as what is being done. We're not quarantining people that are coming in to Europe or systematically. We're not putting them in hotels. We're trying to put them in their home, or sometimes in a hotel. We know our quarantine measure, isolation measure are not covering 100% of cases, because there's freedom issues, and we have to respect the cultural aspect of that. So I think I would like to really underline the courage that has been provided by China in conducting the intervention and the public health measure that have been taken, that really opened the door for other countries to do some things. Because I'm not sure we would have started with that if it was started on Europe. I'm sure we would be in a much more terrible situation if it had started by us. So yeah. So thanks. That was my last point.
So Professor
Wang,
Wang,
just a short comments. Thanks for Professor Hawaii. That's I just thinking about every country select the strategy they adapt. It's based on the culture. So I think the culture exists between the different systems, different countries, Eastern countries, Western countries. So China, adapt this policy or strategy, I think based on the culture and the system of this country. So I can understand very easily that every country like US, they adapt the policy they like, but just like you say, that it is because they accept the situation. What you can accept, what you can, finally the situation will go to, and then I think you were happy with this, the epidemics and all other situations. But for the vaccines, I think personally, I'm not so optimistic about vaccines for the coronavirus. I did not see a very good vaccine like influenza. We don't have actually very good vaccines. Like we needed to one shot each year to protect ourselves. And the SARS vaccine, we did not see the successful vaccines. MERS, we don't have. So it is not easy, I think, to have vaccines in just several years. Maybe we needed to more time to develop very effective vaccines. And for the new virus exist with peoples, we needed to remember that each virus or each bacteria, they come into the population, human populations, in the first time, and then exist, and then in the history of populations, we only eliminate one disease, right, by vaccines. So it is. I think we needed to accept this. Thank you.
last word.
Oh, okay. So yeah, just very short comment. Yeah. So first, sorry being late for this webinar, and I think Professor Wang has introduced a lot of things, strategies, countermeasures against the pandemic in China. And what I want to say that I totally agree with what you said. We have to adapt ourselves to this changing world, changed by the COVID-19. And also, I'm very pessimistic because I really believe the COVID-19 will stay with us for several years or maybe lifelong time. I don't know. Yeah. But as Professor Wang just said, we have eliminated only one infectious disease, smallpox. So, yeah, I just want to say something that my American friends always said that. You see, China is always implementing top-down strategy, or countermeasures against infectious disease. I said, I just want to say that yes, it's okay. So whatever strategy we implement for the pandemic, if it works, then everything is okay. Yeah. If it doesn't work, we have to adapt. Yeah. But anyway, the first priority is we have to adapt our strategy. depending on our context, culture, history, or traditions, whatever. So I think finally we could overcome this pandemic, but we need more time and more efforts, and sometimes we need joint efforts, not only one country, not China, not United States, but the whole country. Yeah. Thank you.
Yes, I totally agree with you, Professor Lu. We don't have one magic solution for all countries. We are different, so genetically it's different as well. So I think we should tailor our methods. So Laetitia, if you still have some comments, otherwise I will inform our audience of the next webinar. So based on our discussion part, so the next webinar will come up 18th of May. So we will discuss the development aspect of vaccination anti-COVID-19. So the speaker will be Dr. Schockman, and we are very honored to have Professor Wang with us for the debate part, and Professor Lu, if you have time, please come as well. So just after that, on Wednesday in the same week, we will have another international exchange with our Chinese colleagues from Wuhan. So Professor Yu Zui from Hospital Renmin of University of Wuhan. So he spent several months in the Yihan Hospital. So as I mentioned before, Yihan Hospital is specialized for the urgent emergency treatment of COVID-19 patients. So he will try to share with us the situation and the strategy of the urgent condition and the therapy management of COVID-19 and also non-COVID-19, because we are facing a very complicated situations. There are some patients, they need to do the operations for other disease. We cannot just ignore them. So Professor Yu will tell us the whole story next Wednesday. So let us look forward to all these exciting webinars. I would like to thank Laetitia for your time, efforts, and excellent remarks for this panel discussion part. Professor Wang, who is unfortunately not here anymore, and Professor Lu, thanks for you to be present today. So very interesting webinar. I learned a lot, and thank you very much on behalf of the organizing committee, and thanks to Ladali and Philip for your hard work behind the screen here, and also Gilbert.
Thanks a lot. Thank you.
Yeah, thanks a lot. If you agree, we will announce the end of today's webinar. Maybe just wait, Professor Wang. Yeah. So thank you very much, Professor Wang. And we finish our webinar today. So see you next week. Hopefully, see you next week. Yes.
Thank you. Thank you.
And thank you very much.
Thank you.
See you.
Thank you. Bye-bye.
Wang An. Yeah. Bye.